Hello everyone and welcome to lecture 75 of this series. This series of lecture is based on my book, Manual of Fluid, Electrolyte, and Acid-Base Disorders, a Pathophysiologic Approach to Common Clinical Problems. I am Dr. Mohammad Tinawi. I am a nephrologist in Northwest Indiana. You can find the book on Amazon as an ebook, paperback, or hardcover. Today we are going to finish our discussion of respiratory alkalosis. Additionally, we're going to do case studies in both respiratory acidosis and respiratory alkalosis. I've shown this slide before. Let's focus on the last part. Respiratory alkalosis is due to a low PaCO2. This results in elevation in pH or alkalemia. It can be acute or chronic. The metabolic compensation is by a decrease in bicarbonate. In the acute case, for every 10 mm of mercury decrease in PaCO2, the bicarbonate decreases by 2, while for the chronic, for every 10 mm of mercury decrease in PaCO2, the bicarbonate decreases by 5. How do we make the diagnosis? We do a history and physical. Tachypnea is common, but we can only make a diagnosis after obtaining arterial blood gases. This is true for any acid-base disorder. In respiratory alkalosis, the bicarbonate is low, but this can also be seen in metabolic acidosis. Therefore, you need arterial blood gases to make the distinction. On the arterial blood gases, the pH is going to be over 7.45 because the PaCO2 is below 35. We usually get complete blood count, urea, creatinine, electrolytes, including calcium, magnesium, and phosphate. Respiratory alkalosis reduces calcium. Actually, it increases the protein-bound portion of calcium, so ionized calcium will be low while total calcium will be fine. Now, respiratory alkalosis causes a shift of potassium intracellularly, in the same way sodium and phosphate shift intracellularly. Usually, respiratory alkalosis is associated with hypokalemia and hyperchloremia. So the potassium is low, and we have to correct it. Now, we need to know what the bicarbonate is to calculate the metabolic compensation. And then we order other tests depending on the underlying condition. Let's take an example. We have a patient presenting with a panic attack. He's having palpitations, shortness of breath, diaphoresis, facial numbness. We do ABGs. Here we have a pH of 7.53, so we call that alkalemia. We look at the PaCO2. It is low. It is 25. So it is respiratory alkalosis. Now we look at the bicarbonate. It's 20. So both are low. That's good. Now, is this metabolic compensation as expected or no? Now, for every 10 mm of mercury decrease in the PaCO2, bicarbonate should decrease by 2 in the acute setting, like this setting. So, since the PaCO2 went down from 40 to 25, it went down by 15. So the bicarbonate should go down by 1.5 times 2 or 3. So the bicarbonate should be 21, and here the bicarbonate is 20. This is close enough. So this is a simple acid-base disorder due to acute respiratory alkalosis. Let's look at a different example. We have someone with a major depression presenting with salicylate overdose. We have nausea, vomiting, abdominal pain, tinnitus, visual hallucinations. We also look at the arterial blood gases. pH is 7.50, so this is alkalemia. PaCO2 is 20, so we have respiratory alkalosis. This is very expected in salicylate overdose. Now the bicarbonate is 15. Is this expected compensation or not? Let's see. Now the PaCO2 dropped from 40 to 20, so it dropped by 2 tenths. And for each 10, the bicarbonate should drop by 2. So the bicarbonate should drop by a total of 4. So 24 minus 4 is 20. Now the bicarbonate here is 15. So it is lower than expected. And a bicarbonate of 15 indicates concomitant metabolic acidosis. And like we said before, metabolic acidosis associated with respiratory alkalosis is very common in salicylate overdose. So this patient has a mixed acid-base disorder. What do? We alkalinize the urine by using a sodium bicarbonate drip. Now, the serum salicylate level in this patient came back at 92 and dialysis was done. What are the clinical manifestations of respiratory alkalosis? Well, acute and rapid alkalosis can cause confusion, dizziness, cramps, numbness due to decreased ionized calcium, of course. Rarely, you can have seizures. Remember that acute respiratory alkalosis causes a reduction in cerebral blood flow due to cerebral vasocontraction. So remember that acidosis will cause cerebral vasodilatation, while respiratory alkalosis causes cerebral vasoconstriction. Alkalemia, whether due to metabolic or respiratory alkalosis, causes a shift in the oxygen-hemoglobin dissociation curve to the left. Therefore, this decreases the O2 release from hemoglobin, and this causes tissue hypoxia. Now, alkalemia inhibits respiratory drive. This is exactly the opposite of acidosis. Alkalemia, like we said, causes hypokalemia and hypocalcemia. And respiratory alkalosis is associated with arrhythmias, atrial and ventricular tachyarrhythmias. That's not good. You can also see cardiac ischemia. How do we treat the patient? Well, it depends really on the cause. Severe hypocapnia should never be corrected rapidly because then you get cerebral vasodilatation, and this is injurious to the brain. You can get also reperfusion injury to the lung. So you should correct slowly. Patients with anxiety and hyperventilation, let just them breathe into a paper bag. That's enough. Patients who are hypoxemic, of course, you're going to give them oxygen. In patients with high altitude sickness, we should give acetazolamide. However, a slower ascent is recommended. Also, they can pre-medicate with acetazolamide. Patients on mechanical ventilation, well, we'll leave that up to the pulmonologist. They have so many things that they can do. They can add dead space. They can do sedation. They can even paralyze the patient. They can change the mode of ventilation. Reducing bicarbonate is helpful, and that can be accomplished by isotonic saline, acetazolamide, very rarely dialysis on a low bicarbonate bath. Now, let's do some case studies. Case number 1. 60-year-old man with acute kidney injury due to hepatorenal syndrome has hyponatremia, sodium 130, hyperkalemia, potassium 6.1, chloride 99, bicarbonate is low 15, anion gap is 16. We do arterial blood gas, pH is 7.13, so we have acidemia, and also you have a bicarb is low, so you have metabolic acidosis by definition, but also you have a PCO2 that is high. So what's the acid-base disorder? So, like we said, at pH 7.13, we have acidemia, pH bicarbonate is 15, anion gap is 16, so we have anion gap metabolic acidosis. Now, the PaCO2 is elevated, so here the bicarb and the PaCO2 went in the opposite direction, while the expected response, the PaCO2 should go down, should be around 29. So you have a mixed high anion gap metabolic acidosis, and also you have respiratory acidosis. Case number 2. 55-year-old woman with chronic COPD and cor-pulmonale requiring diuresis with furosemide and metolazone, sodium 137, potassium is low due to diuretics 3.2, chloride 85, bicarbonate is high at 35, anion gap is 17. We do arterial blood gas, pH is 7.46, so a little bit high, normal up to 7.45. PaCO2 is high, 51. What is the acid-base disorder? We have a pH 7.46. This indicates alkalemia. We look at the bicarbonate, it's high, 35. So we have metabolic alkalosis due to diuretics. Also, we have hypokalemia due to diuretics. That's easy. Notice also that the chloride is low. Now, the incompensated metabolic alkalosis, you expect PaCO2 to be 47. So here the bicarb went up by about 10. When it goes up by 10, the PaCO2 should go up by 7. 40 plus 7 is 47. But here the PaCO2 is 51, so we have mixed acid-base disorder, metabolic alkalosis, and respiratory acidosis. The latter is due to chronic COPD. Case number 3. 58-year-old woman with acute and chronic systolic CHF requiring intravenous furosemide and chlorothiazide presents with low sodium 129. So now you know she's decompensated due to hyponatremia in the context of CHF. You have hypokalemia due to diuresis. You have hypochloremia. Bicarbonate is 40 and ion gap is 10. You look at the arterial blood gas, pH is 7.65, so you know you have alkalemia. The bicarbonate is high, so you have metabolic alkalosis. PaCO2 is 38, PaO2 is low at 61. What is the acid-base disorder? So pH 7.65, you have alkalemia, bicarbonate is 40, you have metabolic alkalosis due to diuretics, you have hypochloremia and hypokalemia. Now, what is the expected response? So here, the bicarbonate went up from 24 to 40. So it went up by 16. So the PaCO2 should go up by 1.6 times 7. So it should go up by about 10. So it should be about 50. The PaCO2 here is not 50, it's 38. So we have mixed acid-base disorder, metabolic alkalosis due to diuretics, and respiratory alkalosis due to hyperventilation due to hypoxemia. And look at the PaO2, it's 61. We'll take this up a notch. 61-year-old woman with ESRD on hemodialysis. She's non-compliant. She had her last dialysis 1 week ago. She presents with uremic symptoms. On exam, she has edema and tachypnea. Chest x-ray shows CHF. Now, sodium is low, 131. Potassium wasn't high. It was 4.1. Chloride, 81. Bicarbonate is 26. Anion gap is high, 24. You look at the arterial blood gases, pH is 7.41, so that's normal. PaCO2 is 42, this is also normal. PaO2 is 65. What's the acid-base disorder? Do we even have an acid-base disorder? Well, obviously we do. If you're looking superficially, you say, well, that's okay. Well, it's not okay, and this is common on a test. This patient is non-compliant with dialysis. She has a very high anion gap of 24. This is due to high anion gap metabolic acidosis. Now, look at the delta anion gap, delta bicarb. The anion gap is 24, so it's up by 14. 24 minus 10 is 14, while the bicarb is 26. So the bicarb should, if the anion gap went up by 14, the bicarb should go down by 14. So the expected bicarb is 10, but it's 26, so it's really elevated. So here, not only do we have high anion gap metabolic acidosis, we have metabolic alkalosis due to vomiting. How do we know? Well, the bicarbonate, instead of it being down, it is up. Now let's calculate the respiratory compensation. We use the Winter's formula. The expected PaCO2 is the bicarbonate times 1.5 plus 8 plus minus 2. So here we get an expected bicarbonate of 47 plus minus 2. The patient's PaCO2 is 42. This indicates respiratory alkalosis due to hypoxemia. So the PaCO2 in actuality is lower than expected. So this patient has a triple acid-base disorder, high anion gap metabolic acidosis due to missing dialysis, metabolic alkalosis due to vomiting, and respiratory alkalosis due to hyperventilation and hypoxemia. Now, even though the pH, PaCO2, and the bicarbonate are all in the normal range, you have a triple acid-base disorder, and because you have triple acid-base disorder, the changes kind of canceled each other out. So be careful. Last case. 28-year-old man with generalized anxiety disorder presents with hyperventilation, palpitation, chest pain. He was diagnosed with a panic attack, sodium 139, potassium a little bit low, 3.4, chloride 105, bicarbonate 22. Anion gap is 12, pretty much normal. Arterial blood gas is 7.49. So here you have alkalemia. PaCO2 is down 30, so you have respiratory alkalosis. PaO2 is normal, 98. What's the acid-base disorder? Well, we said that we have respiratory alkalosis. This is acute due to hyperventilation, due to anxiety. Low potassium is due to intracellular shift, that's expected, and the bicarbonate is like what you would expect. So here the PaCO2 went down from 40 to 30, dropped by 10, so the bicarbonate should drop by 2, and that's exactly what happened. So we have a simple acid-base disorder, compensated respiratory alkalosis, no more, no less. Let's finish with some key points. Respiratory acidosis or primary hypercapnia is acidemia, so pH is less than 7.35 and the PaCO2 is high. This is the mechanism, it's over 45. So here you have alveolar hypoventilation, so the metabolic CO2 production exceeds the ability of the lungs to remove it. The opposite, the mirror image, is respiratory alkalosis. It's primary hypocapnia. Here you have alkalemia. pH is over 7.45. It is due to a decrease in the PaCO2. It's less than 35 due to alveolar hyperventilation. So here the removal of CO2 by the lungs exceeds its metabolic production. In respiratory acidosis, the metabolic compensation is a rise in bicarbonate, while in respiratory alkalosis, it is a decline in bicarbonate. The change in bicarbonate is more pronounced in chronic respiratory acidosis and especially in chronic respiratory alkalosis. The most frequent acid-base disorder is respiratory alkalosis. It's encountered in even some physiologic states like living in high altitudes and pregnancy. It's very common in hospitalized patients. Respiratory acid-base disorders are diagnosed after obtaining ABGs, not just respiratory acid-base disorder, any acid-base disorder. The main treatment is addressing the underlying etiology. This is the conclusion of Chapter 10. See you in Chapter 11.